Good evening, everybody. Myself, Dr. Raghu, working as HOD at Yashoda Hospital, Malakpet. So, Yashoda Hospital brings every week with a different topic with an esteemed faculty in the field of emergency medicine for enriching the students' knowledge, getting the latest updates in the field of emergency medicine, and enriching the students, the new registrars and faculty, and everyone. This week, we have an interesting topic to focus on resuscitation. So focus on resuscitation. Focus is an important topic for all the ER physicians, so, which is now almost like a modern stethoscope or a third eye for the emergency physician. So to talk on this topic, I invite Dr. Shweta Tagi, who is a senior consultant at Bharati Vidyapeeth, Pune. Over to you, Dr. Shweta.
Thank you so much, Dr. Raghu. Good evening, everybody. So, as Dr. Raghu said, so we are going to start off today with resuscitation and how POCUS is a valuable tool, that is point-of-care ultrasound, which we have in emergency department, how it can be a valuable tool for guiding our resuscitation while we are in the emergency department. So should we start off?
Yeah, you can go ahead.
All right. Okay. So I'm sure everybody will agree with me that when we are working in the emergency department, it is always a performance under pressure. So we have to do a lot of things in a very stipulated time with precision and accuracy. So sometimes there might be too many patients, sometimes one patient might be sick with too many problems. So in any situation, it is always a performance under pressure in emergency department. So opportunities for point of care ultrasound in emergency department are any patient who comes in with polytrauma, with respiratory failure, undifferentiated shock or circulatory failure. So all these three conditions, when the patient presents to you in ED, you're not really sure what you're dealing with. So as you are stabilizing the physiology of the patient, point of care ultrasound helps us get to what is the etiology or uh, what is the reason why the patient has gone into respiratory or circulatory failure or shock. So it gives us important clues to really solve the puzzle when these patients come in a very sick and undifferentiated manner to us in the emergency department. So it is a very quick, convenient, it is a dependable diagnostic tool. It gives rapid interpretation of results and helps us narrow down the differentials so that we can make a definitive plan or a definitive therapy can be planned for the patient. Appropriate disposition and referrals can be given. Again, it provides a real-time procedural guidance for many procedures in the ER. Say, for example, putting in a central line or doing nerve ultrasound guided nerve blocks. And then the best part about it is no exposure to ionizing radiation, and definitely it reduces the overall cost of patient management in the emergency department. So, as always, let's start with the case scenario. So, we have a 30-year-old male, as you're working in the emergency department, who's come with a road traffic accident. He's got polytrauma. So, airway, breathing, circulation, there is definitely an impending airway compromise. He's tachypneic, he's in respiratory distress. The blood pressure is 60/40 and he's tachycardic with a heart rate of 150. Now, this is like a typical patient who is breathless, who's also hypotensing, tachycardic. We might have to intubate this patient very quickly. So we need to understand what is the reason of shock for this patient and how do we basically narrow down our differentials here and manage the patient appropriately. So this is where the extended focused assessment with sonography in trauma comes in place. that is EFAST. So we all are aware of the 5 to 6 views which are required in the EFAST. So it's a right upper quadrant view where you see the presence of free fluid but in the Morrison's pouch. The left upper quadrant view where you see the free fluid in between the renal splenorenal angle. Then the subcostal view or the subxiphoid view from which you look at the heart to rule out a pericardial effusion or a cardiac tamponade. Then you see the pelvic view to visualize free fluid across the bladder. Then the sixth and the seventh view is the lung ultrasound where you look at the lung bilaterally to see whether the lung sliding is present or not, or whether there is any fluid accumulation above the diaphragm. So if the lung sliding is absent, then that gives you a clue that it might be a pneumothorax. Or if there is accumulation of fluid above the diaphragm, that tells us that there might be a hemothorax associated with this patient. So EFAST helps us identify these life-threatening injuries, and once we can identify that, then quickly the disposition plan can be decided. So let us see a little bit more in detail. If you see here, you can see this. So there is free fluid in the right upper quadrant view. In the left upper quadrant, this is the kidney and this is the spleen. So that's how you visualize it. Then you have the pelvic view. So this pelvis EFAST is positive here because there is definite free fluid across the bladder. Then you look at the lungs where the lung sliding is present here. So that means there is no pneumothorax. This is the subxiphoid view where you can see free fluid across the pericardial space. So that suggests that there is a blunt or penetrating injury to the heart, which is leading to pericardial effusion. And when this progresses, it might lead to cardiac tamponade, and that might be the cause of shock for the patient. So one of the obstructive reasons for shock. So integrating EFAST in the initial management of stable patients is very, very important. And by getting a EFAST, actually, you are eliminating the need of doing all unnecessary X-rays and CT scan right at the beginning. So EFAST can give you valuable information, but there are definitely some limitations which EFAST has. That is, if your EFAST is negative, still there are chances that the patient can have injury to the abdomen, that is blunt trauma to the abdomen, and injury to the retroperitoneum or mesenteric area or pancreatic area. So all these things might be missed because of EFAST. So if your patient is stable and you really suspect because of the mechanism of injury, then these patients should be subjected to CT scan because that can then detect all these missed injuries. So CT scan definitely is the gold standard, but for unstable patients, EFAST is your rescue choice for investigations. So as we discussed, the important limitations of fast examination are that injury to retroperitoneum or diaphragm is not very well seen. If the patient is uncooperative, the patient is very obese, there is a lot of bubble gas, subcutaneous air is there, which is interfering with the image quality. So these can be problematic. Blood cannot be distinguished from ascites or urine. So somebody who's already got ascites and has presented to you with blunt trauma abdomen, it might be very difficult to understand whether it is actually just the ascites or it is hematoma or the blood accumulation. And also it is insensitive for detecting bowel injury. So considering your mechanism of injury, what you are suspecting, based on that, you need to understand and decide whether you need further investigations for the patient. Now let us go to the next case. While you were managing this patient, you had another 55-year-old male who had fever, multiple episodes of vomiting, and now is breathless. So he is here in the ER, and now when you are examining, airway is patent, the patient is tachypneic, he's got respiratory distress, he's again hypotensive, tachycardic of 160 per minute. But here, definitely there is no history of trauma. It is a medical situation. So now in this case, how do you integrate the point-of-care ultrasound. So this is something what you're physiologically thinking, whether it's an impending respiratory failure or a circulatory shock, or what you're dealing with sepsis. So you need to understand this physiology and then try to correlate the etiology behind this physiology so that correct disposition can be done. So here the RUSH protocol, that is rapid ultrasound for shock and hypotension, blue protocol, that is bedside lung ultrasound in an emergency, false protocol, that is fluid limit administration limited by lung sonography. So all these protocols can come to your rescue. So let us see one by one. So RUSH protocol. Now, whenever you are doing a point of care ultrasound in the emergency department, there are questions you are asking. You are asking clinical questions and you are trying to find out the answer for those questions, because only then there is relevance of doing this ultrasound. Say, for example, when you are having a patient who is in undifferentiated shock. So first you want to ask this question, that is the patient in hypovolemic shock or cardiogenic shock or obstructive shock. So that's how you want to understand what type of shock the patient is. So there is, like in the RUSH protocol, we see it in three ways, that is the pump, tank, and the pipes. By pump, I mean the heart. So is there a cardiac tamponade? So when you see the subxiphoid view, you check whether there is cardiac tamponade. So if cardiac tamponade is absent, that means you've ruled out this obstructive type of shock. LV contractility. So you are checking how much is the EF, ejection fraction, and this is just by the eyeballing. You take a quick assessment as to is it hyperdynamic contractility, or it is not contracting in a effective manner. So the EF is low. So if the EF is low, then obviously there is a reason where the heart is involved. It's not able to pump properly, and that is the reason the patient is in shock. Then the third question you need to ask is there any RV strain? By RV strain, I mean, is there any RA-RV dilatation? So, or is there presence of McConnell sign or D sign? We will come to it a little further also. So if there is RV strain, then that tells us that there can be pulmonary embolism, which might be the reason for this RA-RV dysfunction, or there might be cor pulmonale, which can be a chronic complication of COPD patients. So by asking these questions in the pump, you are understanding whether the pump is the reason for your shock. Then you come to the tank. In the tank, you are doing your EFAST examination. So by fast examination, you are trying to rule out if there is any leakiness in the tank. That means, is there any free fluid in the Morrison's pouch or the pelvis area or the splenorenal angle? So that will help you understand that yes, the patient is losing blood and that is the reason patient is in shock. Then you look at the IVC. By looking at the IVC, you try to see whether there is a kissing IVC. That means more than 50% collapse of IVC with respiration, and whether the IVC is non-collapsing or plethoric or distended. So if the IVC is more than 50% collapsing, that means the patient is in some type of a hypovolemic shock. So patient can be given more fluids. If the IVC is plethoric, not is completely distended, then that suggests more towards obstructive or cardiogenic type of shock. Then you look at the lungs. So by lungs, you're looking at the B lines. So when you see the B lines bilaterally in most of the lung fields, then that is suggestive of pulmonary edema, that is interstitial fluid in the lungs. So pulmonary edema is the reason why patient is breathless. The other things which you can see in the lungs is the fluid accumulation above diaphragm. That can give you an idea of either hemothorax or massive or large pleural effusion, which is causing lung collapse, and that is why the patient is breathless. So based on your history, you can correlate these findings and really understand what is the exact problem in your patient. And then the pneumothorax, so whether the lung sliding is present or absent. So if lung sliding is absent, that can suggest that this patient might be having a pneumothorax. So once you've done the tank assessment, the third assessment is for the pipes. So for in the pipes, we look at abdominal aortic aneurysm and we look at DVT. So abdominal aortic aneurysm, we'll just come to it. How do we rule out both these things? So by doing this assessment, we come to a etiological diagnosis as to why the patient is in shock, whether it is an obstructive shock, cardiogenic shock, or hypovolemic shock. So the things which we just discussed, here you can see there is RARV dysfunction. RARV is dilated. You can also see a thrombus here. And this is a typical McConnell sign where you can see the apex, which is hypercontractile, and a kinetic free left ventricular wall. This is the D sign where the RV is dilated and you can see the left ventricle is, the intraventricular septum is flattened out. So this is the D sign. So both these signs are suggestive of right heart strain, RARV dysfunction, suggestive of pulmonary embolism. Now see the ultrasound appearance or four-chamber view of the heart. This is the normal. By eyeballing, you can understand that the ejection fraction is within normal limits. Here, the heart is very hyperdynamic. So this can be either sepsis or hypovolemia as well. And the third picture, you see the low EF. So you can see that the contractility is severely impaired. This is the IVC appearance. This is the normal IVC. Here you can see it's almost kissing, so suggestive of hypovolemic shock. And here in the third image, you can see a distended IVC, which is hardly collapsing. So plethoric IVC, suggestive of either obstructive or cardiogenic shock. In the aorta, the pipe assessment, which we discussed, we look at the diameter of the aorta. So the diameter of the aorta should usually be less than 3 centimeters. So if it is 3 to 5 centimeters, then that suggests a little bit of dilatation. But if it is more than 5 to 7 centimeters, then it is suggestive of abdominal aortic aneurysm. And if it is more than 7 centimeters, then it definitely is like a large aortic aneurysm, which would require surgical correction, or it is critical, almost having a risk of impending rupture. So identifying the abdominal aortic size is again one very important feature, because any elderly who presents with disproportionate pain in abdomen and you are able to detect the abdominal aortic dilatation, the disposition of the patient can definitely be fast-tracked and the patient can be handed over to the cardiothoracic unit and appropriate disposition can be planned. Again, presence of flap. So you can see flap in the aorta. It can be a suggestion of aortic dissection. So again, pain which is tearing type. So considering your signs and symptomatology, so looking at abdominal aortic aneurysm and aortic dissection can help us get the clue towards these potentially lethal diagnoses. In the pipe assessment, apart from the arteries, we also look at the veins. So seeing a clot or non-compressible vein. So both these are indicators towards presence of deep vein thrombosis. So if deep vein thrombosis is present and the patient is breathless and there is RARV dysfunction, then it is an indirect clue that this patient has pulmonary embolism. So for screening the patients, for DVT, only 2-point assessment is required. So bilaterally, you need to check the femoral and the popliteal vein. So if any of this is positive, then it is considered positive. So what is about the false protocol? So false protocol is just a what to say, further step to rush protocol where you identify whether your patient is in obstructive shock, cardiogenic shock, or hypovolemic shock in the manner as I discussed previously. And once you have detected hypovolemic shock, you can also monitor your patient when you're giving fluids. So if you're giving fluids and the patient starts to develop B profile from A profile, then that means the patient is developing a fluid overload state and pulmonary edema, and we have to go slow on the fluids. So this also helps us, other than identifying the type of shock, also helps us decide how our fluid and vasopressor or inotropic strategy for that patient should be. So this is a little bit in brief about the lung ultrasound. So you can see this is the pleural line, the barcode line on the M mode. This is suggestive of pneumothorax. This is a lung sliding which is positive, that is, which is present. So it is normal lung. And here the lung sliding is absent. This is the curly B line. So more than 3 to 4 vertical lines coming from the pleural line, that is called as curly B lines, and this is suggestive of pulmonary edema. There are few other signs which can be seen, that is, this is called as shred sign. So if you get a shred sign, this is suggestive of consolidation. So that means the patient has got pneumonia. So either community acquired pneumonia or ARDS, depending on whatever the signs and symptomatology the patient has. So this is in short the blue protocol. So in blue protocol, you look at the lung sliding. So if the lung sliding is absent and there is A profile, if there is a blue lung point, then the diagnosis of pneumothorax is confirmed. But at the same time, if the lung sliding is present and there is B profile, then it suggests pulmonary edema. When lung sliding is normal and there is A profile, then you need to look at the thrombosed veins. If there are thrombus in the vein, it is suggestive of pulmonary embolism. And if the veins are free, then you look at the shred sign, etc. If that is present, then it goes towards pneumonia. And if that is also absent, then it is like a exacerbation of COPD or asthma. So this is basically a decision tree based on blue protocol. So considering your physical findings and the history of the patient, comorbidities, etc., you need to look at the profile which the patient has, and based on that, a combined, you have to correlate it all completely and understand that what the diagnosis can be. So not only in the lungs and the heart, even ultrasound can provide accurate diagnosis for fractures. So skull fractures can be predicted. There can be, a suture and a fontanelle can be uh, uh, understood, and there can be, if there is a skull fracture, that is a depressed skull fracture, then further diagnostic strategies like CT brain, etc., can be planned. Another important thing in emergency department where ultrasound can help us is pupil examination. So sometimes in trauma patients, the eyes are completely closed and we are not able to open the eye because there is a base of skull fracture and the patient has raccoon eye and there's a lot of swelling, lid edema, etc. In those cases, ultrasound-based pupillary examination can help us understand whether the reflex is normal in both eyes, whether the pupil is reacting equally in both eyes. if there is any anisocoria. So all those things can be detected. The other important thing which we should understand is the optic nerve sheath diameter. So this is again a very easy examination where you can see this as the optic nerve sheath, and it correlates directly with the intracranial hypertension. So ONSD greater than 5 mm is suggestive of raised intracranial pressures. So that can help us again understand that what our strategy in this patients should be. To summarize, there are a lot of things which we can do in the ultrasound during our resuscitation, as discussed in all my slides, which can help us guide in a patient who has presented to us with polytrauma or undifferentiated shock or undifferentiated breathlessness. This is a summary bullet where we can make this particular kind of a chart for our departments. So while we are examining the patient by POCUS during resuscitation, we can mark all these findings, and as a snapshot, then we can understand and decide what the diagnosis is based on the clinical findings. So this can really help us get to the correct etiology and decide the disposition in a faster manner. Thank you so much.
Yeah, that is a wonderful presentation by Dr. Sweta, explaining from the ABCs of the ultrasound. Now, ultrasound has become a basic tool in the ER, which has become a third eye. So, for all, as she said, for all the undifferentiated, whichever shocks which we are, with the patient cannot be shifted to the CT console. So, where without exposure to the radiation of the patient, we can do the bedside, even overtaking the X-ray, which will buy the time for the patient and for all the unstable patients, which can be taken to the OR directly from the ER based on the surgeon's confidence level. So she has rightly pointed out the rush protocol, the blue protocol, the false protocol, and the ONSD very beautifully. So any doubts from the audience, she'll be ready to take. So as we are doing the ABCs for all the critical patients, so these ultrasound also has now become from the ABC also, from where we examining the optic nerve diameter, then checking whether the patient's ET tube is confirmed or not, then checking the bilateral air entry, whether they're having any, whether the patient is having any pneumothorax, then any pneumothorax, then when the cardiac tamponade, then lastly the DVT. 1 minute. So you have a question, Shweta.
Yes.
What is lung pulse for lung ultrasound?
So in the lung ultrasound, what we do is we see the rhythmic movement of the pleural line, which is synchronized with the heartbeat. Now, this helps us understand that whether there is, it helps us understand whether there is effective aeration of the lung, that is to rule out a pneumothorax basically, or a breath holding spell, or maybe something to do with adhesions. So in those cases, this can help us understand.
Okay, we have one more question. In ultrasound eye ball, madam, when eyes are closed while scanning, how can we see for the anisocoria without light?
No, without light, we cannot see. We have to put light. We have to shine light in the eye. Even when the eye is closed, it doesn't matter. You have to shine the light with the closed eyelid. And when you put your linear probe on the eye, you can see the contraction of the pupil with the closed lid itself.
Okay. Any more questions from the audience?
I feel point of care ultrasound, I mean, the more and more you use it, the more and more avenues it opens, and it gets more and more interesting. It gives you very valuable information to actually do resuscitation at the bedside and take meaningful decisions.
Yes, the more the use, so without any other investigations or the CT or your X-rays, these can be minimized in the year, so
Yeah,
which can buy the time for the patients to be shifted to the OR in the unstable patient.
correct.
So as you use on, you get expertise in the field of your point of care ultrasound.
Yeah, so once you are really, up to it, doing it, you can like finish doing rush protocol, blue protocol, like less than 3 minutes. You can visualize everything and just tuck, 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 rule out all the life-threatening issues. I mean, it's like almost like a visual stethoscope.
So if there are no questions, we will wind up the session. Thank you, Sweta, for the wonderful session,
Thank you,
giving
Doctor.
insights of the point of care ultrasound,
Explaining
all,
all in detail for the
and I thank Yashoda Hospital in association with Seni and Anbai for giving a weekly different topic from the experts in the field of emergency medicine, whereby the students are getting benefit every weekly. So if nothing is there, we'll close it. Bye, Shweta, and good night.
Bye. Thank you so much, Dr. Raghu.
Yeah, thank you.